I know we've met before, but I wanted to introduce myself again. I'm Jessie. I am a staff nurse here at North Kansas City. I work currently on Maine. I've been a float nurse. I've worked on Maine before. My certification is in progressive care. I've had other certifications before. I'm also trained and certified as a forensics nurse examiner. I don't do that at this facility. I've done it at a different facility. I've worked in dialysis. Most of my 15 years experience has been in the hospital. I've also worked in home health, hospice, and I did a very small stint in a clinic. So today I want to talk to you guys about trauma-informed care. Is that something we are all familiar with? We've heard it's kind of a buzzword in healthcare, and we can advance. So what is trauma-informed care? Does anyone want to give me a quick definition? Anyone want to speak to it? What have you heard about it?
When I think about trauma-informed care, I think about like all of that patient's past experiences and like being empathetic to that and like bringing that into their care.
Yeah, and why would we want to do that?
Because that is the filter in which they are, you know, perceiving what you're doing for them, and yeah. And so like when we come at somebody a certain way, we may not think that we're coming at them aggressively, but they're seeing it as aggressive.
Right.
Or whatever.
Right, because no two patients are the same, right? Mm-hmm. Even if they're the same age, demographic, race, religious background, and diagnosis, they're not the same, right? We treat everybody a little different. Go ahead. Trauma-informed care is recognizing the signs and symptoms of either actualized or threatened trauma in our patients and delivering empathetic care reflecting this understanding. So exactly what you said. Very good. All right. Okay, it's their why. Like, maybe let's take an example of, I don't know, Miss Johnson. Miss Johnson, you've had her for 4 days. She's lovely. She's pleasant. You know, you getting along, and you're on your 4th day, and you're like really tired anyway. But Miss Johnson is lovely, so you're happy to take care of her again. Miss Johnson gets her dinner plate, and there are no mashed potatoes, and she freaks out. You ever dealt with a scenario like that? Like, what's happening? Okay, so have you guys heard of the ACEs study, Adverse Childhood Events? Okay, it was done in the 90s. So adverse childhood events are events that happen from 18 years and before, so in your childhood, and there's a whole host of them. Emotional abuse, physical abuse, sexual abuse, substance abuse in the household, mental illness in a household, any sort of domestic violence in the household, divorce or separation of parents, emotional neglect or physical neglect. And I, please don't raise your hands, but I would venture to say that most of us in this room have had at least one. Okay.
Oh,
Yes.
sorry.
Okay, so the ACEs study, this is kind of convoluted, but I'll try to explain as best I can. It was, the study was done by the CBC, and I think Kaiser Permanente in the 90s. Next, you can just go. There were 17,000 participants, okay? So these participants weren't kids. They ranged all different ages, all different ethnicities, all different religious backgrounds, educational backgrounds, and financial backgrounds, okay? They were all in Southern California, I believe so. And what they found, they hypothesized that there was a relationship between those adverse events and a person's basic health and wellness, okay? So this is the framework of the ACEs study. Can you guys all read? Okay. So it's a little convoluted, but at the bottom is generational embodiment, historical trauma. There's more to it than like historical stuff, right? So this would be like, if you've ever heard of like, oh, it was passed down from the mom, sort of a thing. So if your mom had certain traumatic events that happened to her that shaped her, those events are shaping her relationship with you, which is where this is coming from, okay? Race, social conditions, and local context. What's going on in the home? Are we living in below the lines of poverty? Are we able to go to school? Stuff like that. Complex trauma, ACE, multiple traumas. There's a lot being talked about right now with like complex PTSD and stuff like that. So it's multiple traumatic events, right? Allostatic load, anyone familiar with that term? It's the buildup of chronic stress and how it affects your body over time, and it's not good. Disrupted neurological development. So when kids are abused and neglected, they can have cognitive delays. It can cause behavioral problems. Sometimes it's permanent, and that's what that is, okay? The next level, coping, adoption of health risk behavior. We've all seen, the top three is what we see actualized in our patients a lot of times. So coping, adoption of health risk behavior. It's the alcohol misuse. It's the substance abuse. It's cutting, behavioral disorders that result in physical disorders, right? Or like the person who is an adrenaline junkie and they're just putting their lives at risk every day, right? Burden of disease or stress, criminalization, and stigmatization, that goes without saying, but it's the people that end up incarcerated, that end up with a heart disease from the buildup of chronic stress, and then early death. So the more ACEs that you have, the more at risk you are of being higher on this pyramid, okay? We can go on. This is about 3-minute video. I think it's pretty great. In 5 seconds, it'll be great. 2 seconds.
I get really mad when my brother hits me a lot. I don't like it when you say you don't want to play with me. When I'm mad, my brain can get a headache and it can start hurting. Your blood keeps pumping because you're like really mad. And you start to get sweaty because you're getting really, really mad. And then when you start getting really mad, you turn red. When your body can't really control yourself, mad just takes over your body. I just get out of control. It's kind of like if you had a jar and then the jar would be your brain and then you put glitter in the jar and that would be how you would feel. If you shook up the jar and the glitter went everywhere, that would be how your mind looks. And it's like spinning around and then you don't have any time to think. And you sometimes punch stuff and people when you don't really mean it. When I get angry, I feel it in my heart. I really don't like when I get angry. The amygdala really reacts, but the prefrontal cortex tries to keep it down. When I feel like I want to, get really angry and yell, I just sometimes, take deep breaths. First you find a place where you can be alone, then you find some way to relax and calm down. When I need to calm down, I take deep breaths. I breathe in through my nose. Sometimes I close my eyes or just take deep breaths. It's calming down, it's not moving. It's slowing down and then it stops. And the heart pumps slow and then it goes into your brain. It's like all the sparkles are at the bottom of your brain. My brain slows down and then I feel more calm and then I'm ready to speak to that person.
resonate with you guys? That video is made by a couple of filmmakers, and they used their kids and some other kids from their school, I think, and it was completely unscripted. Like the kids, that was all from their hearts. But those feelings that they had, isn't it those the same feelings that we all have? How articulate those kids are, you know. We learn a lot from children. Anyone want to talk about it? We can move on. Okay, so what do you guys think are some disruptive trauma response behaviors? So these people who have had all this trauma or have unknown trauma, how do they respond in a hospital scenario? When you guys see them, what are you seeing? Anxiety, yeah. Anger, yep, we see that. No, we never see that, do we? Anyone else? And also, if this makes you uncomfortable, please don't feel like you have to participate, okay? Okay, we can start. Clicking. Agitation and aggression, absolutely. Anxiety, nail on the head. Difficulty communicating. Do you guys ever experience patients that have difficulty communicating with you? And do you find yourself becoming annoyed with that behavior? Maybe there's, good. there's probably a good reason for it. Non-compliance. These are the people that are coming in and out of the ER, the hospital, and they're like driving us crazy. Like, why don't you take your meds when you go home? Well, maybe they don't have money to afford their medications. Maybe someone is not taking them. Maybe someone's controlling their car, their financial stuff. We just don't know. But emotional outbursts, absolutely. Next, I think there's maybe one or two more. Hypervigilance. Those are those folks that are like constantly on you, watching you, asking you questions, hitting the call bell, like they're always on alert. That's a trauma response. And disassociation. Those are the folks that, anyone on oncology, oncology? Those are the folks that have been just diagnosed with some cancer. Maybe they're 30 years old and they've got colon cancer, which seems to be happening more and more. And they are like, not even, like they're laughing and like it's not, like they're not making sense. Like they're just not picking it up. Avoidance. Those are the people who just don't want to talk about it. They probably know what's happening. Those are the same colon cancer patients that they know what's going on, but they don't want to deal with it. Maybe they want to go home, and they're probably not going to go back to their doctor. So how can we manage those disruptive responses? What do you guys do when you see that stuff? Anyone want to offer feedback? What do you guys do? What do you do when someone screams at you? Or when someone's dissociated? How do you respond?
Well, most times when people have anxiety, I do like deep breathing exercises.
Yeah.
Like that focus and then just responding nice.
Yeah. Trying to see under that layer, right? That layer on top. We all got a lot of layers underneath. We, as work nurses, right? We don't have great days every day. And a lot of us are dealing with some of these traumas, right? And sometimes taking care of these patients can be triggering to those traumas, right? It's hard. It's a hard job. Okay, so recognizing the triggers. So let's take Miss Johnson with the mashed potatoes. She freaks out. What can we do next time? I mean, it's so simple, right? We just make sure there's some mashed potatoes on her tray, right? Or we call and order her food, or we check the tray before we go in. Creating a safe environment for both the patient and the clinician. You guys have probably taken or will take the HANDS class. Is that right? With security?
They probably have it, yeah.
Yeah. And security, they're wonderful. We'll get into them in a minute. Keep going. Clear communication, use of calming and soothing voices, appropriate body language, active listening, preparation and explanation for upcoming events and activities of daily living when possible. So we are very busy. Yesterday, I think I lost my mind working day shift. And a lot of times we're just trying to get our tasks done, so we're running in and out of these rooms, just doing stuff. How many times do we really tell our patients what's happening? What are we doing? Are we knocking the door and, hey, it's Jessie. My pronouns are she and her, you know, I'm gonna be your nurse today, what can I do for you? Or are we just trying to get our stuff done, right? So goes a long way for us to slow down and tell our patients what's happening. And if they are not with it enough to know and their families are in the room, tell their families. Validate feelings. Miss Johnson's mashed potatoes is so ridiculous, right? That she's freaking out about it. But to her, it's not ridiculous, right? It's like a real thing that she's upset about, and she's probably upset about 500 other things. But validate her feelings. De-escalation. Security is really, really good at that. So if you guys have a patient that you can see is like, oh, you can kind of tell when they're starting to like level 1, level 2, level 3, and you're like, oh God, they're gonna get to level 10. Just de-escalation techniques, the soft, soothing voice, getting down on their level, making sure you're always close to the door and that the door's open. Don't shut your doors when you're in the room, shut the curtains, right? If you have a patient that is at risk for this. And if you can't do it, call security and they'll come do it. Providing choices when possible. So if someone's really upset, give them some choices. You can try to trick them into doing what you want, right? But give them some choices about how they're gonna get to it. And creating boundaries, which is really important if you're dealing with violence. Trauma versus everyday stress. So what's the difference between trauma and everyday stress? Anyone? Okay. So trauma, it's okay. It's okay. This is like really sensitive stuff and I don't mind. As long as you guys don't mind. I'll be being on with. So trauma is an event. It's something that happened. Or it's like the feeling that's impending, an impending event is going to happen. Everyday stress is just a response to a situation. Trauma is chronic. It can lead to lifelong symptoms and problems without treatment. Even with treatment, it can be lifelong. And it impacts your daily functioning, unfortunately. Everyday stress is situational. When the situation ends, stress ends usually. And it doesn't disrupt daily functioning. It might disrupt a couple days of functioning, but it doesn't carry on.
Sorry.
No, you're good.
Shut that door.
Okay, so trauma-informed practice. Okay, the 4 R's. So if you can just remember these 4 R's, you're gonna do great. And you probably already do them and know them because you guys are awesome. So the first is to realize, that there is layers to people. There's layers to their behavior, there's reasons, there's a why. There's always a why. Recognize. So when you know that there's a why, recognize maybe that what's happening is only it's very shallow and there's much deeper stuff that's going on under the surface. Respond. So then we respond to it, right? And it's different in every situation. And I truly trauma-informed care, I am like not even scraping the surface of what it really is and how we practice it. It's like a whole weekend retreat. I could go on and on and on. And then resist re-traumatization. And you want to talk about that. So when we re-traumatize someone, we're putting them right back in that place where they were traumatized. And there's a million scenarios and how we can do that. So the goal is not to do that. So how do we practice trauma-informed care? Collaborate with social work, case management, providers, chaplain security, charge nurses or supervisors, SANE nurses, or anyone that's appropriate to the care of the patient. So whatever you can do to help that person, let's try to do it. Mindfulness, that Just Breathe video. We can teach our patients breathing. That's not always applicable, right? But we can certainly use it because, like I said, there's a lot of times when their behaviors, it triggers something in us that makes us uncomfortable or upset. We've already done the self-care stuff, so you guys have the tools already. Empathy, have empathy for our patients. It's their, worst day, and maybe it's not their worst day. Maybe their worst day, we have no idea what that day was. And their behaviors are reflecting that, even though we don't understand it. And be aware of your own prejudice, triggers, and act in the best interest of you and your patients. This is hard because we see these knuckleheads all the time. And it's hard to care for knuckleheads all day. But we gotta check ourselves, right? And try to understand that maybe there is a lot more going on than we see. Okay, so case study 1. Okay, let's talk about it. Yeah.
Okay, here we go.
Mr. Lee is a 67-year-old man who is admitted to a cardiac observation unit for chest pain. Mr. Lee speaks English as a second language. He has no known medical history and takes only a multivitamin. He has all the stuff, 12 lead, CAT scan, chest x-ray, echo. Everything has been negative, as well as his labs. He has continued calling out intermittently and grabbing his chest despite the negative workup, requesting pain medicine. His nurse holds his pain medicine. He becomes quite upset. The nurse questions calling security. His doctor has placed discharge orders. No new meds have been ordered upon discharge. Okay, so what are the red flags here? Anyone see red flags?
Yeah, well, I mean, obviously, the nurse holding pain meds.
Because everything is negative.
Well, but pain is pain.
Yeah, yeah. She's not validating, right?
English is his second language. We don't know anything if like a interpreter's been in to kind of help with that.
Yep.
Because chest pain could just be anxiety. And,
Yeah.
That way they could educate him on what's going on with him and
Yeah.
a little bit better.
All right. Anything else?
They're discharging him, but he still is experiencing the symptoms that he can't.
Yeah. Okay, we can move on. Good job, you guys. So what's going on? Mr. Lee has recently lost his wife of 50 years. They got married young, apparently. He is retired. His children live away in California. He speaks English but doesn't understand medical terminology. He has never been seriously ill and can't understand why he's having chest pain. Mr. Lee is having symptoms related to the recent loss of his wife. He is not grieving well, but his children don't know. I think there's one more. So what could we have done to help him?
Obviously.
What should we have done?
Definitely gotten that interpreter to like
Yeah.
conversate with him.
Yeah. Yeah. Anything else? What should we have asked the doctor for? Maybe. I mean, I don't know. What's right? There's really no right and wrong answers here, guys. It's it's like a restaurant menu of options. Maybe. Do you think he could have used something for anxiety?
Yeah, some like Ativan or something.
Yeah.
I thought if they asked him his history, they would have known what was going on immediately, because that's part of your job when someone comes into the emergency room to ask them like what has been happening
Yeah.
recently, like have you had any falls, etc. And if someone spoke whatever his first language is, or had like the inkling to ask for an interpreter at the beginning,
Yeah.
it would have been something that would have been quick to recognize.
Absolutely. And maybe we could have gotten the social work team involved. Right? They should be involved, but. Okay, case study number 2. Mackenzie is a quiet 26-year-old female private payer presenting to the ED with abdominal pain. That they never see that, right? Any ED nurses in here? You never see that, right? She is accompanied by her boyfriend, who accompanied her to every exam. Vital signs are blah, blah, blah. They're all stable. This is the 5th time Mackenzie has presented to the ER in this past 12 months. CAT scan of her abdomen is within normal limits, so it's an ultrasound. UA is positive for a UTI. UDS is also positive for methamphetamine, THC, and opioids. Mackenzie has been discharged from the ER with a script for oral antibiotics. What are our red flags?
I don't like that the boyfriend followed her everywhere.
I don't like it either.
And it's slipped in
And she's
time.
quiet.
And she's
Right.
quiet. Bingo. What else?
Why do we keep getting, what did we come for the last 5 times?
Yeah.
Right, is it the
Hey.
same thing that's happening? Cause,
Yeah.
and is she, like, what's her home meds like?
Right.
Is she positive for methamphetamines because of medications that she's taking at home? Her opioids, is that because of pain meds that she was prescribed from the last visit?
Mm.
Is she self-medicating?
Right.
Oh, you guys don't need me. Okay.
They're good, aren't they? I'm so proud of them.
I know. So what's going on? Mackenzie is a victim of human trafficking. Her boyfriend is perpetrator. So you guys nailed it on the head.
In the private payer part, isn't that also like?
I just added stuff in there to kind of, you know, to the whole, you're getting the whole picture, right? Of course she didn't have insurance. She's a victim of human trafficking.
So they could've given a fake name to avoid
Oh.
insurance. like they
100%.
really is
By the way,
insurance.
when I did my SANE nursing, these are all examples of patients-ish that I've actually seen. I've seen this. So, okay. Number 3. Mary is a 74-year-old woman who lives with her son. She has been admitted to the ortho unit after traumatic fall at home. Mary is alert and oriented to self-in-place only. History of hypertension, chronic UTIs, osteoporosis, dementia, breast cancer. When she was admitted, she was soiled, scattered bruises, various shades of color. X-ray showed chronic fractures to T6, T7, and a hairline fracture to her left wrist, which has been immobilized with a brace. All the other workup has been negative. Son has not been present, but the case manager has confirmed that he's able to pick Mary up at discharge, and she's going home today after being cleared by physical and occupational therapists. I'm pretty sure is what that says. What are our red flags?
Multicolored bruising.
She's
multiple
soiled.
UTIs.
Okay. So what's going on? She lives with an alcoholic son. When he's intoxicated, he often becomes impatient with his mom. Prior to her fall, Mary was interested in what her son wanted for dinner. She already ate. He didn't want her in there, so he yanked her wrist, pulled her back, she fell. He went to sleep because he was intoxicated. When he woke up, he didn't really remember anything that happened. He called 911, got someone to the hospital. Yikes. Right? We didn't do our due diligence with Mary, did we? So what should we have done?
Not discharge her home with it.
Yeah. Or done our best to, right? Sometimes no matter what we do, it's out of our hands.
Yeah, but you're a mandatory reporter.
You are a mandatory reporter. Yeah, and I've seen this too. At this hospital, social work team does the hotlines. But you can do them too. And in Missouri, it's online.
Even without pointing the finger, you could have spoke with the family and just been like, hey, you know, mom's got all these chronic illnesses. You know, have we considered long-term care?
Yeah.
Memory care?
Yeah. Yeah. It would have been nice to get a face-to-face with the son, right? Number 4. Stacy is a pleasant 36-year-old woman who's been admitted to med-surg following routine chole. Vitals are fine. She has been discharged home with oral Zofran, Norco. She lives with her 3 young children and her husband. She calls her nurse in tears requesting to stay another night. This has never happened to you guys, right? Nurse apologizes but gives her discharge instructions. Right on, nurse. That's what we're supposed to do, right? Her husband is not able to come to the hospital at discharge, so arrangements are made for Stacy to go home by cab. What are our red flags?
Why is she crying?
Why is she crying? Why is she crying? We can move on.
I'm so into your story, I'm sorry. I feel like I'm gonna cry.
Poor Stacy, I know. Look, you guys, Stacy has an abusive husband.
Yeah.
Okay. She's been suffering emotional abuse from her husband since they were married. She's worried that he will be difficult when she gets home. Even though she needed surgery, she's concerned he will be angry. They're having financial trouble and she believes he will take it out on her. She's worried about paying for her care. What could we have done different for Stacy?
She was worried about going home.
What's her why? That's it. If you guys only have one takeaway from all of this nonsense, it's the why. What is their why? I want you guys in the back of your head always to be thinking about the whys. Okay? Number 5. Ben is a 21-year-old man who's been admitted to the progressive care unit following an ICU stay for respiratory distress. He's grossly obese. Fire department had to use a crane to rescue him. He's withdrawn but cooperative and pleasant. He lives with his mother who cares for him. Ben's mother stayed with him throughout the hospital stay, making his medical decisions for him. He's learn-oriented, by the way, I didn't add that. Nurses have been frustrated with taking care of Ben as he is bedridden and incontinent. The social work team has found a rehab facility for Ben, but his mother is insisting that he be discharged back home. What are our red flags?
Why is mom?
Why is mom so nosy and in his business? Yeah. Any other red flags that you see?
He's 21.
He's 21.
Yeah.
Yeah. Anything else? He's grossly obese.
Why is he not?
Why? Yeah. Why? There's a lot of whys, huh? Yeah, it's sad. I've also seen this. It was a female, but I've seen this. Okay. Ben has suffered extensive abuse since age 5 at the hands of his stepfather, who's now deceased. To cope, Ben compensated with food and withdrew to his room. His mother refused to leave her husband and never believed allegations of abuse. Ben never left his home because he felt as if his mother needed him after the death of his stepfather. Oh, right? Awful. What could we have done for Ben?
Ask what led for him. I mean, I don't know how much he weighed, it wasn't there, but you could ask what was, like, how did we get to this point?
Yep. Well, I think I'm over my time, right? You guys have any questions, concerns? Good. You guys, yeah. If you do, you can find me.